Good afternoon. This is Dr. Bill White again with the American Orthodontic Society, and we're stressing preventive and interceptive types of orthodontic work and how it should be done, and started out when a child is very, very young to prevent this from happening. The patient that I'm going to show you today is an engineer, and he's up, I'm sure, in his early 30s, something like that, and he has developed mouth breathing from a youth up, and his mouth breathing causes his tongue, well, if you're going to breathe through the mouth, there's no question about it, you have to put your tongue in your lower arch. That's just absolute must. And you breathe over the top of your tongue, and nothing gets up into the palate. The tongue doesn't wad up and press out on the palate, so you develop these cross bites. Now he's got a bilateral cross bite here. Let me get into the patient and let's really talk about this thing and what we're doing. It ties right into this preventive and interceptive stuff. Now, this is he's a neat guy and everything, but you look, the chin is kind of off to this side of the mouth, you see, and his nose comes right down through here, and the facial structure, the jaw is longer on this side than it is on this side. And I don't mean to talk about him. He's a real nice guy, and I really like him. And I'm sorry that this ended up happening to him because somebody neglected to get him started off right. Now, I am one for children nursing when they're young. They really should be nursed if it's all possible. Maybe we could find something that would substitute for nursing, but I don't know what it would be. I was in the hospital with my wife here just the other day, and one of the nurses that came in had perfect teeth. And I got to talking to her, and she's an Indian from Mexico. And her great-grandmother, somebody, married a Spaniard. She was fairly light complected, and she had just beautiful teeth. And she has 5 sisters, and all of them have beautiful teeth, and her brothers. And they all nursed about a couple of years or so between children there. And nursing, I think, really causes you to develop this airway back in here. If a child is nursing, they cannot breathe through their mouth. They have to breathe through their nose, and they develop the whole nasal capacity there. And I was in Africa years ago and had a whole school that came in, and I had no orthodontics work. I did all the orthodontics in that school. I pulled 1 supernumerary tooth. Everybody else had beautiful lined up teeth. I mean, it was just unreal. I didn't have a good camera, didn't even have a camera then, and I didn't get it. This was in about 61 or 62 when this happened. And I've wondered why for years that none of these children had any orthodontic problems. And I've come to the conclusion the African children usually nurse about 2.5 or 3 years. They stay with their mother. They don't get any protein anywhere else, and that's kind of forced on them. My wife also lived out in the woods, the Kisatchie National Forest, and she nursed till she was 10 years, to nearly 3 years of age. And she had perfect teeth and never saw an orthodontist, you see. So I think this is where this lies. Now let's look at this fella's teeth. I mean, see how they're crowded up. Normally they would be spread out more, and if the tongue was in the right position, they would have done it. Now, it didn't cause him to have too terribly much more vertical height of the face. Right in here, that's not bad, and his vertical height of the face isn't all that bad. But let's go and look inside the mouth now, and he's in a semi-crossbite. See how these teeth, these upper teeth should be out here, lined up over those lower teeth. Now this part right here, that one's almost okay. That's a little bit in here, but he has bilateral crossbites. In other words, the maxilla up here has not developed like it should, and the lower arch is spread out further than we'd really wanted. Let's take a look at him from the front. Now his tongue was down in here. He probably had a mouth breathing, and normally you get a tongue thrust problem too, and so this is opened up in here, and the maxilla is too narrow, and these teeth are crowded out, and even this has got some crowding down here. So there may be other causes too, but this is a mouth breathing functional problem that should be dealt with when the child is really young. And you don't sit around and wait on this person to get to be 12 or 13 and send him in to get his orthodontics. And I don't know that he came to me because we thought we could separate his palate, or we spread his palate out, and he didn't get any surgery. But I bet in many places they would have done surgery up here to expand this palate. And that's really making the cost of something go up, that you could have stopped the development of this young man and the allergies and all the things that get him breathing right. If you'd have done it even earlier, it would have helped his facial structure and everything. Now, over on the other side of the mouth, again, crossbites. These upper molars should be out like that. See, holding that out. And I'm a big proponent, the one that's in favor of this, because I'm the mouth breather myself, and it's been a problem all my life. I should have had my palate separated. Now when we look at the upper arch, you see, and this is the maxilla, and you can see it's not spread out the same on both sides, and he was in a crossbite, and you saw his right side of his jaw was kind of out to the right a little bit. It wasn't just dead center, it spread out evenly. Okay, let's look at the lower arch now. I'm afraid I've got my marking pen off here. I'm going to have to hunt that up and get that going. Let me just a minute here. Okay. All right. This left side of the jaw is in crossbite too, and you're breathing through the mouth. There's no way you can breathe under the tongue. You're going to breathe over the tongue, and your palate is going to go without the tongue pressing on it and developing it. And I didn't mention this. Like, you look at the palate now on this young man, and you see the tongue has not been up here. If it had been this, these teeth would be spread out like that, you see. And you put the tongue in there. A lot of people think the tongue doesn't have much effect on it. The tongue can move your teeth all over the place. You just can't imagine. If you think the tongue won't move your teeth. I had a guy that was about 40 years old, came in and his front teeth was sticking way out like this, and I could not figure out what on earth did it. And finally I left to talk to some of the patients, and he told the young lady that was in the room with him says, I've been trying to stop smoking, and I put these lozenges up in my roof of my mouth, and I hold them up there with my tongue, and that pressure caused his front teeth to stick out like some kid that was sucking his thumb all the time. I mean, the tongue moves the teeth. It's pretty doggone constant in there. And so you can see the lower arch is spread out wider. The tongue is not real wide because he had his mouth open, looks like, and he was sticking the tongue in between the front teeth, and they don't come together again. You can just tell so much about a person just looking at their mouth. Just take pictures of it. And so you see it here again. We started this young man in 06, and we got through in about 08, I think, something like that. And this is his models. And you see how the tongue went up in here. A lot of times he'd swallow and push it out, but the tongue was basically down in the lower arch nearly all the time. And that caused these teeth to miss this. And a lot of times people will shift their jaw completely over so they can chew better on one side, maybe the other side's in a terrible crossbite. They'll have a unilateral crossbite, and you think it's a unilateral crossbite. Well, most all the time it isn't. It's a bilateral crossbite, and they just shifted their jaw over to do that. And looking at it from this side, this is the models. I'm going to show you all the pictures, and then the lower arch is wider than the upper arch, and he's breathing through the mouth, and he's breathing over the top of the tongue, and the top of the tongue is in the bottom arch, it's not in the upper arch, and that has caused this problem this young man has. I'm not sure right here, he may have some habit of pushing on that, but the tongue is broader in here. These teeth fit in here. He's got a crossbite over here and on this side, the bilateral crossbite. All right, looking at it from the back of the model, you can see the teeth is just a complete open bite up here in the front part of the mouth. And we took a gauge here and measured the width of the lower arch from these molars. This is not real accurate, but then went ahead and we went through the orthodontics. I put a palatal separator in, if I remember correctly, and I don't have a picture of it. I'm sorry of it, but we spread his palate out. I mean, this is spread out. So the upper teeth you see are up like this on the lower teeth, both sides of it. In here, we spread it out, and we widened this thing out. We got it where it could breathe through the mouth. If you don't get rid of the problem, then you're going to have a heck of a time retaining a case like this. You've got to get, if it's all possible, to the problem, the source of the problem. And allergies are a real pain because they're hard to get rid of the allergies. I've experienced that myself. But here we're doing this as little narrow brackets as we use, but you see the upper teeth are out over, and the lingual groove, the cusp of the upper teeth fit in the lingual groove of the lower teeth, and the rest of it's just plain orthodontics. And I wanted to bring out, this is an older person, and I'm almost sure he told me that he had been to one or two places and they wanted to do orthodontic surgery to spread this out. And we are able now to separate people in their 30s and some of them in their 40s by putting force between the upper centrals right in here. That's where most of the bone is. And the palatal separator is right back in here. And we're trying to push the major part of the bone up here from pushing in this area. And that just ain't mechanically very good to do it. So we put the force here, and we can push them, separate palates in their 30s and 40s, and not too many in their 40s. Now they get to where you can't or do it. And I've got a video on a guy, we just kept kept putting pressure on it, we actually stretched the bone structure in the roof of the mouth, and of course it's up high, and as you stretch it out, it'll get down lower, you see, as it goes across there. And here's the lower arch. We rounded it out and done all the good things here. We teach this guy how to swallow and breathe and make sure he doesn't have a lot of allergies or adenoids or whatever's blocking the airway. Work with an ENT guy to get somebody that works with you on that will get rid of tonsils, adenoids, or even reduce turbinates and different things to get an airway for everybody you work on if you possibly can. That's the secret of it, and so that's what we're pushing: preventative, interceptive orthodontics. And this is a neglected section of orthodontics, and not too many orthodontists really want to get into this, but it is an essential part of orthodontics, preventive and interceptive stuff. And you can do it, and you just have to get to where you look at somebody and you can tell darn near what they're doing. And we've got him moved around like that, level his arches out and everything, get him breathing right and swallowing right. You bite together when you swallow. If you swallow with an adult pattern, you bite together with several pounds of force, and you bite your teeth together to swallow about 2,000 times a day, and you put that force back on the teeth, and over a period of years you can get the vertical height of the face to lower to some extent, but that's hard to do. And most of the time they're going to go in and do orthodontic surgery to do it. And I've scrubbed in on these operations and even helped them sometimes. And I'll tell you, if you can avoid that, God, that is the best thing to do. See, I cut the separator out right here. There's where the separator was on the molar, and we had these teeth banded. So when I spread this out, the roots of these teeth go with it, and that widens this whole airway out up above. And that has to be done. We can do that on a lot of older patients now, and that is a good thing to do. And here's the lower arch after we've spread it out. The tongue fits in there just real nice, but the tongue is going up in the roof of the mouth. Now this is a mirror in the mouth, so it looks like you got something down here, but really this is the tongue showing over a mirror. And here are the models. After we finish, you can see we cut this palatal separator off and kept the band on that 6-year molar and put a band on this second molar here. This one isn't rotated good, but we're not through with it when I took these models right here. And there's how wide it was to start with, and there's how wide we got it. See, this needle went from here around to there. Let me go back and show you. This is where it was about between 1 and, not 1.5, but about a 1 and, it's a little over 4 in there. And now let's go back and let me show you the others. I've got to erase this thing off of there. Okay, now this is it. It's finished up, and we took the band off the 6-year molar and kept it back here and tied that together, you see, to close that. Now we had to put little kinks in this arch wire to make the root of this tooth go like we wanted it to. And I tell you, you cannot do beautiful, correct orthodontics without having to bend a few wires, so learn how to do it. And you can make the teeth do anything, just almost anything within reason of what you need to have done with attaching something to the tooth and working. You see we bent the wire here, and that makes this root. If that wire would go in here, the root would go up that way, see. If you expand this cuspid, you darn sure better have the root going distal to the crown, you see. Okay. I'm getting ahead of myself here. Whoa, I don't know what I did. All right. I don't know what I did there either. I think we're at the end of our deal, and I appreciate you watching this. I took a little longer than I wanted to, but this brings out what I've been trying to come across with. Preventive and interceptive orthodontics has got to be done from an early age, and it's ridiculous to think that you can get over here in a pediatric practice and send this person out for every little thing orthodontically you need to do. You need to learn how to do it, or else you get in a group and hire yourself an orthodontist and get him over there and get him doing all of this preventive and interceptive.